Dear colleagues, it gives me a great pleasure and honor to start this session, which is focused on beyond the trial, how will SELUTION DeNovo redefine our PCI practice? I am honored to be shared with Dr. Awaida Shimri, Dr. Hussein Hishmet, and Dr. Thomas Johnson to discuss many aspects of today's talk. The learning objective of this talk is to review initially the SELUTION data that we had lately, the trial results, then to understand the technology behind the new drug-coated balloon and what makes it special. And lastly, to study the implication of these balloons in clinical practice. The session will be as such that initially Tom Johnson will present the SELUTION DeNovo changing evidence, changing practice. Then we have a panel discussion. Subsequently, Professor Hussein Hishmet will talk about real-world Gulf experience with the drug-coated balloon solution. We will be followed by another discussion time, and then Tom Johnson will talk to us about DEB decision-making in complex situation with case-based approach. With that, I would like to ask Tom Johnson to start this talk, please.
Thanks, Ibrahim. So it's a great pleasure to be here, and we are obviously a relatively small group, so I'm sure we can interact with each other without the use of the application. But if you want to post questions on the application, you prefer it that way, we can hopefully respond to them using the iPad at the front. So I'm just going to briefly outline the results of SELUTION DeNovo, which were presented at TCT just under a month ago by Christian Spalding. I participated in the study and have then done some additional kind of consultancy work with Cordis. These are my conflicts. So I was really excited heading to San Francisco and was writing a whole load of talks and got myself down a little bit of a rabbit hole. But I just want to share with you this kind of consideration, which is that we're in this position now where we potentially have different modalities that we might use for our destination treatment, be it a stent, which we're most familiar with, or potentially a balloon. But actually, regardless of which we choose, we have to keep focus on the fact that we're looking for a good patient outcome. And so from the point of presentation, acute or chronically, we're kind of pursuing the diagnosis, and then ultimately we make a decision around stenting or ballooning with hopefully a happy patient thereafter. And it got me quite excited. I started developing this talk and discovered that in California, there's a place called Stent that I am going to have to go and visit. But there is actually somewhere in California called Stent. And then I got really lost in my total ludicrousness, but thought about the fact that maybe there are lots of roads to Stent, but actually not all roads lead to Stent. And so what we're going to focus on now is the use of a drug-coated balloon. And there is a slight caution that when you then magnify on Google Maps the town of Stent, there is a stent cemetery. And so the reason we're here is that potentially we're avoiding the stent cemetery. So sorry about that slightly circuitous route to getting you to the importance of SELUTION DeNovo. But actually, it's a really important study, and importantly, the design was such that it was a strategy trial. This is about recruiting patients to one concept against the one we're most familiar with, which is stenting, and I'll touch upon that. So here's Christian presenting those results, and I'm just going to literally run through those slides. The reason that DCB has created kind of noise is the fact that we see this attrition of all generations of stent, both in the first 12 months, but thereafter there is a risk that we can have stent thromboses and restenoses, which potentially could be avoidable if we didn't use a stent in the first place. It is important to understand the technology in the SELUTION SLR balloon is distinct, and so it is a sirolimus-eluting balloon, and it uses these small particles, micro-reservoirs, to hold the drug so that there is a release over a period of time. The concern, most of the literature is around paclitaxel balloons. Paclitaxel is lipophilic. It will attach to the vessel wall. But obviously there are issues around potentially the cytotoxicity of that drug, and the limus agent is preferable, but the challenge has been about its delivery. So the balloon is coated with a phospholipid coating, and onto that are these micro reservoirs that allow this sustained release. And this is some really elegant data demonstrating that actually the elution kinetic of the SLR balloon is equivalent to the elution off a stent, very different to other limus-related drug-coated balloons that have a much more rapid delivery of the drug. So the study, as I've highlighted, was a strategy trial, and the most important element to this is that we randomized patients prior to any treatment. We've taken an angiogram, we have evidence of disease, and we say, are we happy to treat by balloon, or would we be happy to treat by stent? And as long as the answer to both of those was yes, then we would proceed. And the patient is then randomized either to the drug-eluting balloon strategy or the stent strategy. And factored into that was the expectation that within that drug-coated balloon, drug-eluting balloon arm, that there would be patients that we have dissection or we failed to adequately expand, where we have to deploy a stent. So the stenting is actually part of this strategy. So we are comparing this approach, not just necessarily the balloon, against a stent strategy. The first endpoint, which was presented last month, is the 1-year target vessel failure rate. But assuming that non-inferiority was reached at this time point, then most importantly, we go forwards to a 5-year assessment, both of TVF from a non-inferiority perspective, but actually looking then to see whether not leaving anything behind is superior. So the intention is actually to move forwards to this 5-year time point. It was a very broad inclusion. We included anything between 2 and 5 millimeters. We could treat multiple lesions. The only things we avoided reasonably were STEMI, hemodynamic instability, left main, chronic total occlusion, in-stent restenosis. So this was de novo disease only. The intention was to treat the vessel in terms of preparation, achieving no more than a 30% recoil, avoiding severe dissection, and if physiology was used, achieving these metrics. This was very, very infrequent. And the approach to the adaptation included all tools that we're familiar with. So there were cases of atherectomy, and certainly in Bristol, we recruited lots of patients with IVL into both arms of the study. The UK actually recruited just over 1,000 of the 3,500 patients, but this was an international study of over 60 sites, 62 sites in total. This is where maybe an area of kind of debate has occurred, which is around the statistics behind it. So there was some difficulty in terms of anticipating the potential event rate. So assuming a 6% event rate, they looked at a potentially 50% difference between the arms. But in view of the fact that they weren't confident in terms of the absolute metric and a fear of potentially underpowering, they used a kind of a dynamic approach of using 50% without defining an absolute assumed event rate. So if with this example of 60%, then the confidence interval, the threshold is 3% for non-inferiority. What Christian reported in San Francisco was the full analysis set. So this is the full composite of patients that undertook this strategy, of which a proportion were stented against the stent arm. So 1,600 in both arms. Broadly, they were well balanced. So we see an age in the sort of high 60s, majority male as we'd expect, the usual comorbidities. Christian identified that actually there was a significant number of high bleeding risk where potentially leaving no stent behind might help in terms of antiplatelet strategy, and about a third of patients were acute coronary syndrome. In terms of the way that we went about treating these lesions, it was about 1.5 lesions per patient. A significant number, 20%, were proximal LAD, and about 2/3 were in vessels over the size of 3 millimeters. And significant calcification and complexity made up a significant proportion of the cohort. Christian purposefully highlighted radial in a US meeting just to identify this was a European study. About 90-95% were radial approach. The specialty balloon was obviously more in the drug-coated balloon arm, but actually not as much as was perhaps anticipated, and the imaging rates were in the order of 15 to 20%. This bailout rate or provisional stent usage rate was just under 20% per lesion, 20% by patient. And these were fairly complex procedures in both arms taking just under an hour. So the primary endpoint, the TVF rate in the stent arm was 4.4 and in the SELUTION SLR arm was 5.3. So an absolute difference of 0.9. And so the non-inferiority margin of 0.244 was met with the upper limit of the confidence interval coming in at 2.38. So a cheer went up, the p-value was 0.02, but non-inferiority was achieved in this study looking at the 1-year TVF rate. So most importantly, we move forwards then to the 5-year results. This is the KM plot showing, slight separation out to 360 days, but again, there is no real difference between these. And I think importantly, when we think about the kind of safety element to this, we actually see numerically less cardiac death, similar amounts of target vessel MI, and the difference is really observed in the TVR that is observed in the SELUTION arm of the study. And again, looking at these other metrics, again, very, very similar. The secondary analysis is interesting, and I think the ones to highlight here are a gender difference, where oddly in the women there seemed to be this favouring in the DES, but importantly, or sorry to just go back momentarily, we see actually a sign that high bleeding risk patients and actually the calcified lesions seem to do better with drug-eluting balloon. So there were limitations in terms of, this was a pretty broad inclusion, but there were, as I've already told you, certain lesion types that were excluded. This reflected European practice in terms of the preparation and the use of imaging. There's some work still being done by the core lab in terms of QCA. And importantly, that this is something that can't be deemed class effect due to the unique nature of the technology. So he summarized by highlighting this was a large and pragmatic study where there were no obvious safety concerns with the use of this approach, that we used 80% of the patients in the arm of the SELUTION balloon received the balloon not requiring a stent, and that we achieved very favorable results and look forward to the 5-year outcome. And so the conclusion was that we've met non-inferiority and moved forwards. So I'll leave it at that, and maybe we have some discussion.
Great, Tom. Just a question. I don't know if you have that, if you have the information. So they selected 3,000 something patients, 1,600 in each arm. What was these numbers were selected out of what? How many people were screened?
So this was a prospective study. I can maybe only give an answer to that in relation to my experience in Bristol. So we recruited 140 patients in Bristol, and it was all comer in the sense we approached patients prior to their angiogram. As I've shown you, you made the decision in terms of randomization to either the stent or the balloon after you'd taken the angiogram. So pragmatically, we were approaching patients at the point of consenting them for the procedure to participate in the study, so without the knowledge of the angiography. I've shown you about 30% were acute coronary syndrome. Now in the UK, 70% of our work is acute coronary syndrome. So that reflected maybe a different approach in Europe, where a lot of work is stable disease. So they may have had a CT that gave evidence that they knew there was something to treat. So you may go in and recruit that patient slightly differently to the acute coronary patient, where we just don't know until we've seen the angiogram. But we really did recruit all comers. I mean, we had a significant number of IVL. The imaging is an issue. We recruited, actually, we did 90% imaging in Bristol. So we'd taken an approach where we were going to use it to an extent to the concern of the core investigating group, who were worried that by us using imaging, we might convert to stenting more frequently. In actual fact, I'll show you a case later that shows where I think the imaging gives you some greater confidence in terms of what it is that we're doing. And I think the interesting issue around this concept approach of ballooning rather than stenting is we want dissections. We've just come out of a session where we were really focusing on whether we could or couldn't leave a dissection in the setting of a stent. actually, when it comes to wanting to get a good result here, we're seeking injury. So we have to change our mindsets in this approach. And so I think that's going to be the challenge in terms of how we deliver this from an educational perspective, in giving people confidence to actually get out there and cause injury in order to get the best effect from the drug in the longer term.
I think it's the circle came around quite a long time, from the balloon, bare metal stents, drug-eluting stents, and we're going back to balloon. Okay, I think it's going to take time for people to absorb the information, and including myself. I mean, you will be worried about not stenting a dissection, which is by default what you create when you balloon a lesion. You don't know if somebody's going to call you in the middle of the night to come back to the hospital. So that's the worry everybody's going to have. And it's like anything else. I think it's going to take time for people to understand where they can use this technology with the promise of the new micro reservoir and the sirolimus. Yes, let me give you. You have to hold it. Oh, okay.
Yeah, I mean, what Brahim was mentioning is the key thing. So we're all looking now at drug-eluting balloons. Is it a comeback, or is it something that's going to help us in our daily practice? So as a comeback, it's the 5 years. So, stenting, or let's say dilating a lesion today and leaving it to drug-eluting balloon when you could have easily stented it, okay, with good margins, landing zones, and whatever. You wonder, why are we doing this? But 5 years of this study and other studies will give us better information. But really, today, we have situations where we do not want to put a stent. And that's where we're going to have to learn how DCB is really helping us. I had the other day a case of an STEMI, osteal LAD, okay? But the circ was awful, bifurcating from the left main, right, and then the osteal of the LAD was closed right there. 90% osteal circ. Downstream, there's a lot of circ disease. And in the middle of the night in this STEMI, you don't want to put a stent that jail the circ and have to do a left main bifurcation, let's say stenting on a STEMI. So I left it with a drug-eluting balloon. It turned out it was a good result, and I'm going to, we'll follow the patient and see. So to your point, the main thing, I worked for several years in an era where there was no stents. And of course, getting up in the middle of the night for an acute closure was the biggest nightmare. Did this study, for example, look at the drivers of those 20% or so stents that were, crossover?
Yeah.
And I'm wondering, an operator like myself who has worked at the time of balloons versus somebody who has not, would the pattern, would the approach change?
Yeah.
In other words.
So I think that I didn't include it, but actually at last year's PCR, Simon Eccleshall, one of the co-PI of the study, presented the first 1,000 patient data with some really important information there demonstrating a learning curve. So actually within the cohort of the 62 sites that recruited, we were learning as we went along, if I'm honest. I mean, I think my use of DCB prior to taking part in the study was woeful, was really poor. I was using it in cases where we were getting a bad result and I didn't want to place a stent, and so inevitably you have a bad result. This is different. This is saying I'm taking a de novo lesion and I'm going to try and get as good a result as I can, and if not, I'll convert to stent. So the point at which you would provisionally stent was when you hadn't achieved 30%, under 30% under expansion, you were left with a dissection you were worried might abruptly close, or there was physiology. They were the kind of issues. So at that point, you would stent. What we saw in the first 1,000 patients was that there was, between the first 20 cases and thereafter the cases that investigators recruited, there was a reduction in the number of patients that we crossed over to, but particularly post-drug balloon. So you could then deliver the balloon and then say, I'm not happy, and stent. And what we saw most definitely in that time period was people becoming more confident following the delivery of the drug-coated balloon that they'd done enough and the result was good. So there is a learning curve,
and
undoubtedly.
Is there a comparison between POBA and DEB in terms of positive remodeling down the line? In other words, usually with POBA, we used to see the result that will not improve with time. I mean, you start with that and then you factor in elastic recoil restenosis, whatever. But it seems with this, it's a different biology. So with time, you could, and there has been demonstration of lesions post-DEB and a few months down DEB that have improved. We don't see this with the old regular. We didn't used to see this with the drug, with the regular balloons.
It has been studied that 60% of paclitaxel patients, they see positive remodeling, and 30% of the sirolimus, they see the positive remodeling. So if this one of the things that I may choose one over the other. There is no class effect between them. But if I need the vessel bigger, I'll go intentionally paclitaxel. If it's big already, like static, I'll go intentionally sirolimus. Otherwise, they are the same.
Professor Heshmet.
So I'm glad to be speaking after Dr. Johnson, because I'll be giving you the other face of the coin. He was discussing trials that were published in 2025, latest technology of microreservoirs. Forgive me, but I'll be giving you studies from the 1990s and will be speaking more of very basic concepts of balloon angioplasty and stenting, of course. These are my disclosures. And I was introduced to drug-coated balloons 11 years ago. And I went into this slow journey of slowly adopting and increasing their usage. And in the last 4 years, when I counted, 80% of the cases ended up with a DCB and 20% of the cases only ended up in stents. But the common feature and the mindset change that I need you to grasp is the lesion modification. And I need you to forget about drug-eluting balloons or drug-eluting stents. They are both good when they are done properly, but don't forget lesion modification. Unfortunately, in the last 20 years, we were taken into the stent malapposition, the stent under expansion, the geographic miss, and the stent strut thickness and the strut fracture. And so we tended a little bit to forget why do we do angioplasty and how do we do it. So for the majority of cases, it's going to be a DCB unless the lesion modification fades, unless it's a STEMI with a heavy thrombus burden, unless it's an aorto-osteal lesion. We don't have strong evidence yet in these conditions. And also, I'm a little bit skeptical about some cases of in-stent restenosis that are due to stent fracture or calcified new intima, because unless we modify them properly, then drug-coated balloons may not be the best option. So let's go back to the concept of lesion and modification. What lesion are we talking about? We're talking about the atheroma. It starts probably in the teen age, in the early 20s, as a fatty streak, and then it keeps growing to become a plaque, and then it keeps growing to become an atheroma. And oma in Greek means like a tumor, like a swelling. So we have a swelling that's growing inside the vessel wall, and it has one of two pathways. Either the benign pathway where they reduce the flow and they give us stable disease. And then there is the catastrophic or the acute presentation where they rupture with a strong inflammatory component and they give us the acute coronary syndrome. And now borrowing the mindset of the surgeons, if you have a tumor that's occluding the lumen, or if you have an abscess, you need to drain the abscess, it's an acute coronary syndrome, or the benign tumor, you need to excise at least this tumor in part or in total. And that's what we try to do with angioplasty. In the old days, I was so naive. I used to think that angioplasty works by stretching the vessel, by stretching the elastic components of the vessel. And then we realized that no, balloon angioplasty works by attacking the plaque. It fractures the plaque, it denudes the surface of the plaque, It allows the components of the plaque to be released into the circulation in a controlled environment of dual antiplatelets and heparin. And so this is how we tackle the lesion. We drain the abscess, the acute plaque, or we denude, or we take a big part of the bulky plaque in chronic coronary syndromes. And so it's very easy to understand that once you fracture the plaque, then you will create a dissection. And maybe I quote Antonio Colombo, that he said once that interventional cardiology will progress when we realize that dissection is part of the treatment. We shouldn't be scared of the dissection, and I tell you how we do it. So after we modify the lesion, after we break the plaque, the body will react. How will the body react? Well, an attempt to healing. And probably the best description of this healing process comes from Bernie Meyer. The old guys here in the room will remember him. He was one of the first generation of balloon angioplasty with the big guy of balloon angioplasty. And he described in one of his very nice papers about the neo-intima. And the neo-intima is the attempt of the body for healing, because we create injury to the vessel. With stenting or with balloons, we injure the vessel. So the vessel will try to heal this by giving smooth muscle cells, by neo-intimal hyperplasia, by endothelial cells. And these cells, number one, are very resistant to thrombosis. When you do an in-stent restenosis, you notice that the balloon is slipping, because this neo-intima is slippery, so they don't thrombose. And if you look at any trial comparing DCB and drug-eluting stents, the only consistent feature, even with the bad ones, is that MI is exceedingly low with drug-coated balloons because of this neo-intima that is resistant to thrombosis. But neo-intima can keep growing until it blocks the vessel. That's why we need to intoxicate this neo-intima by a drug at the time of lesion modification. So how do we modify the lesion? This is a whole new science. It's not new, but the data is coming. And up till now, it's rather an art rather than a science. For STEMI, it's thrombectomy, thrombus aspiration. For simple lesions, it's a semi-compliant balloon or non-compliant balloon. And in the last 2 years, I'm adopting a very low threshold to use scoring balloons and cutting balloons, because they give us a controlled dissection, and their ability to break the plaque in an organized manner is much better than the semi-compliant or non-compliant balloons. For calcified lesions, we go for IVLs, we use rota, and then balloon or stent, orbital atherectomy, you name it. But this is where you need to invest. Before indulging into DCB or drug-eluting stent, focus more in your lab, invest more on these lesion modification tools. And then when you modify the lesion to the best of your abilities, now it's time to think. And we give ourselves time. We modify the lesion, then we take the injection, and then we keep waiting for 5 minutes. We discuss football, the games, we discuss anything that we want. We ask the patient, how is he doing? And then we repeat the angiogram again. We look for 3 things: flow, the residual narrowing, and the extent of the dissection. And usually the TIMI flow is easy to understand. There's no issues about that. But the main confusion comes from the residual narrowing and the dissection. So, and when you have a residual narrowing 30 to 40, there are lots of inter-observer variability. I would see it and say it's 30. Another one would see it and say, no, this is 50. How do we resolve this? In my opinion, the best probably would be physiology. Imaging is coming, but we still don't have the criteria, the right criteria, statistically proven to tell us that this lumen area is enough and this lumen area is not enough. So I like to count on physiology. Why do we accept residual narrowing from the start? Because of the phenomenon Dr. Ziad has just mentioned, which is late vessel remodeling. We see that with DCB. We see that the vessels tend to grow because we broke the plaque and we created the nice dissection and we infused the drug into the plaque. So the tendency of the plaques to grow again is significantly reduced and the vessel tends to grow with time. And we usually don't see that with stents because stents is like placing a cage for the vessel that prevents it from growing. Going back to physiology, probably the biggest data come from South Asia, and they found that an IFR or an FFR, of 0.75 is the cutoff. If you reach 0.75, then you should be happy with the result of lesion modification. If below the 0.75, then you need to do further work. In my practice, I like to go for higher values. I like to cross 0.8 or try to reach in the late 0.89 when I go for the IFR with DCB. So we try to resolve the residual narrowing with physiology or imaging, and then dissection, the biggest fear of that I see. Now I'll take you back to the older studies of the 1990s. And this is in the early days of angioplasty, before stents were available in 1992. And what the operators did here, the investigators did here, is that they did the balloon angioplasty. It was also the early days of IVUS. And they correlated the extent of the dissection by IVUS with the chances of restenosis just with plain balloon angioplasty. The first finding is that dissections can be seen angiographically and not seen by imaging, and the other way around. And they graded the extent of dissection from A until D, where A is the least dissection, just a small linear tear, B, where the tear extended into the media, C, where there was separation of the torn ends, and D, dissection is more extensive, involving 360 degrees of the vessel. So these were the 4 grades. And they also looked at E, where there was no dissection at all, where angioplasty just stretched the vessel. There was no dissection. And then they got these patients again, and they looked at restenosis. And probably not the surprising finding that restenosis was highest 50%, where there were no dissections. Whereas those with type D dissections, they had 0 restenosis. And the message here, when you dissect the vessel, then you treat the lesion. When you dissect the lesion, then you treat the vessel. And remember now, dissection should be your friend. A similar study was done lately in 2020 by a group from, again, Southeast Asia, and they tried to make it in a more objective way. They created an index, they call it the dissection index, depending on the depth of the dissection and how longitudinally extends into the vessel. And they found that on follow-up, the bigger the dissection index, the bigger the late luminal enlargement, which gives you some reassurance that dissection is part of the angioplasty. But not all dissections are benign. So how to differentiate the benign dissection that's going to be on your side versus the bad dissection that you will be scared they will call you in the middle of the night because of an abrupt vessel occlusion? And I like the acronym ARM by Simon Eccleshaw and colleagues, where A is avoid. Try to avoid a massive dissection. Who's more likely to get a dissection? Elderly, females, patients with acute coronary syndromes, tortuous lesions, oversizing of non-compliant balloons, multiple dilatations. So try to avoid that. And then we recognize, looking at the patient's chest pain, ECG changes. If the patient has continuous pain and there are ECG changes, then this dissection is something. And then we look at the flow, of course. If there's any impairment of flow, then this dissection is dangerous. And we also look at contrast hanging. If you see hanging contrast in the vessel wall, it means that the false lumen that we created is getting flow, it's filling with contrast, but it's not draining, which means that a few hours later, it can keep expanding and compress the true lumen, and then we run into trouble. And this classic description of dissection, I think it's outdated. It's very hard to remember 7 grades of dissection while you're working in the cath lab. So we looked into the data from Colombo and his colleagues, and me, Dr. Shihab, from the UE. We came up with this acronym to make it easy for the operator to remember. We came up with the numbers 30, 3, 30. If you have a dissection with more than 30% residual narrowing, then you need to treat with a stent. If you have a dissection where the contrast keeps hanging for 30 seconds, then you need to stent. If you have a dissection that is associated with impairment of flow, then you need to do something about it. And for simplicity, I said if you have any of these 30 criteria, you stent. But actually, there are some rabbits that you can keep in your sleeve and bring them out for the dissection. We have these tricks from the old days, like a prolonged balloon inflation. And more recently, the scoring balloons or the cutting balloons. And there's a technique that was modified by Gasparini. He used to call it the cuttering technique, where he takes a properly sized cutting balloon in the dissection area, he inflates it, and he keeps dottering it in an attempt to tear to create a fenestration in the intima, so the false lumen communicates with the true lumen, they become one chamber, and so there will be no risk of expanding the false lumen and compressing the true lumen. If none of these work, then please go ahead with stenting. It's not shameful to put stents in these days. So I'll take you through, if we have time, for a few quick cases. This is a 48-year-old gentleman who presented with crescendo angina, and he had an old non-ST elevation MI. You see here the severe stenosis in the mid-circumflex. It's clear in both projections. So we went ahead and we used an NC balloon. That was a straightforward lesion. So that's what we got. You see there is a linear shadow of the dissection here, but the lesion has improved. The flow is great. So we went ahead with a long solution, 3.5 by 30, and we like to go also always with long drug-coated balloons. There's no penalty because there will be no permanent implant, and you will be covering a long segment of the vessel that might harbor some plaques that can rupture in the future, so you give the patient the best safety possible. And so this is the final result after the solution. I'm sorry. And so this is the final result. We have some dissection here, but there was no pain. The flow is TIMI-3. There's no significant residual narrowing. And we were happy. The patient went out. He remained asymptomatic for 5 months. And then he presented for another reason. He came with acute bronchitis, and he had some chest pain. We were not sure that is from the cuff or it's angina. So we took him for a CT angiography, and that's an advantage of drug-coated balloons. You can easily image the vessel again without having the issue with the blooming artifacts of the stents. Anyhow, he came back 8 months later with some chest pain, and this time my colleague doesn't believe much in drug-eluting balloons. He decided to take him for angiography, and you see here the results. The dissection has disappeared completely, the vessel is growing, and there are no issues at all. Let's go for even more complex cases. A 51-year-old gentleman with type 2 diabetes, with extensive 3-vessel disease, advised to go for bypass twice, and he kept resistant after seeing 2 surgeons. You see how bad the disease is in the right coronary artery, and the disease was not much better in the left coronary artery. We said, okay, let's start by the RCA. We did lesion modification to the best of what we can, and you see here that there's some dog boning, so he had real tough lesions, so we had to go for a high-pressure balloon, and the lesion yielded at 20 atmospheres. And it wasn't easy to deliver anything through this extensively diseased right coronary artery. And so this is the result after the lesion modification. I can leave it for a few seconds, maybe to get your opinion. Who would be happy leaving that, and who would be more cautious and go for stenting? If we apply the 3330 criteria, then none of them exist here. Yes, sir.
Yeah, I'm happy to leave it.
Yes, there is a dissection here.
It's called type B.
Sorry?
In the past, the type B dissection.
B, C, yeah.
Anyhow, we went ahead with our DCB strategy, and you see here the advantage of DCBs. We placed 30 plus 40 plus 40. So we used more than 110 millimeters of drug into the vessel without any piece of metal. The patient was fine, discharged on the next day, And then we called him 2 weeks later for the LAD and the circumflex. And so this is the final result of the LAD and the circumflex. But of course, everyone is eager to see what happened to the right coronary artery. So that was the angiogram on the conclusion of the procedure. And here is the follow-up angiogram. I'm sorry. The dissection is still there, but the flow is great. Mind you that usually the golden number is 40 days. For the body to heal and for a dissection to clear, it usually takes like 1 or 2 months until it heals completely. This procedure was done 1.5 years ago, and the patient is still following up. He has done an exercise test, and it was negative, and he's completely happy. If we have time...
The time's actually over. We're running over.
So
but,
I'll go to the conclusion slide.
Yeah.
I needed to forget about DCB or drug-coated balloons. The aim of the angioplasty is to disrupt the atheroma. It's the lesion modification. And the aim of the drug on the balloon or the stent is to suppress the neointimal hyperplasia. Modify the lesion, relax, look at the residual stenosis. You can fine-tune that with imaging or physiology. Look at the dissection, anticipate, modify, and recognize. The rule of 30, 3, and 30 is going to be very helpful in the cath lab. This strategy will work for small vessels and for large vessels. Thank you so much.
I think, Tom, we go to your talk right away. And then keep all questions. We'll do that after Tom's. Tom, you're going to tell us everything technical about this now.
So I'm going to show another case, actually, which nicely leads on from saying with the use of some imaging that might give us a better understanding of quite what those dissections mean. So this was actually a patient that recruited to the study, and I've presented this previously, but I think now in view of the results and having seen, as I showed, really the difference that we observed in 2 arms of the study were driven by target vessel failure. This actually is one of our patients that is one of the target vessel failures within the DCB arm, and it gives an interesting reflection. So she's a 75-year-old female. She presented as an acute coronary event with anterior wall changes. She had significant risk factors. And this was her angiogram. And I guess the reason for showing this is to show the complexity of the disease that we recruited to the study, certainly in Bristol. But this is horrible left-sided disease. So clearly the focus is this significant bifurcation lesion related to a large diagonal, but there's very diffuse distal disease. So as I said, this was a strategy study. You recruited at the point you had the angiogram. Are you happy to stent? Are you happy to balloon? Yes to both? Proceed. People happy to recruit to the study? Yes? Okay, fine. So at the same time, if you're going to stent it, are we going to be provisionally stenting the diagonal? Are you going to treat all of it? What do you do? Yeah. No. So if you're recruiting to either a DEB arm or to the DCB arm or the stent arm. Yeah. So these approaches, is it going to become a 2-stent? Can you treat this? Are you going to injure the side branch and the main vessel prior? Actually, some of the considerations conflict when we think about which arm of the study we're going to. She recruited to the DEB arm. So I focus really just on the level of the bifurcation and avoided the distal disease. So 2.5 actually creeping up with a relatively undersized balloon initially for fear of causing lots of dissections. This is a 2.5 balloon just to the LAD, and then I imaged. So this is the IVUS, and the IVUS shows actually a relatively healthy distal landing that will be in this area here. Bit of dropout there. We see the wire coming in from the diagonal. We see a very high burden of disease. I'll give you some still frames. So we see a 3.5 vessel proximally. We see about a 3.0 vessel distally. I've IVUSed the diagonal as well, just maybe for the purpose of time. Impressively, and I guess cautiously, the measurement of the diameter of the diagonal by IVUS is quite large. I don't think I'd have angiographically have assessed that to be 3.0. So I proceed to some further preparation. So there is then a 3-0 non-compliant balloon to the diagonal and a 3 and a 3-5. So 3 to the distal limb of the LAD bifurcation, 3-5 to the proximal. And now we see very aggressive dissection by IVUS. But I think importantly, we see significant lumen. So although there's lots of injury, we've got good lumen. But comparing this short run of the IVUS against what we see on the angio, we obviously see these kind of hazy areas intraluminally, which are due to the vessel injury we've caused. But we've actually got, in my mind, a pretty reasonable result at this point. Yep. But it's ugly. So we have to be happy to leave these sorts of appearances. So from a point of view of where we're at, I actually went on and proceeded with application of the drug-coated balloons. This was actually a protocol violation because we're not meant to be deploying both balloons at the same time, so you should do it sequentially. And actually, we're just now embarking on another study specific to bifurcation, led by the Bifurcation Club. So EBC-DCB is ongoing around some of these technical issues. Another protocol violation was that I put the probe down after having deployed with the drug, and ideally we should just be happy with the result that we have angiographically. But again, it shows a really hideous dissection. I shouldn't have done, so I got slapped on the wrist. Not that many, I don't think, because I learned pretty quickly. I got told off. So this all went through Core Lab fairly instantly, so you got a pretty quick return. So, and it also was evolving over the course of the study. But you know, is this a B? Is it a D? Is it? I think this is all very arbitrary. And as Hussein says, this isn't really fit for purpose anymore. We talk about either flow limiting or non-limiting, and the 30-330 is a really nice metric to use, which I hadn't heard before. Now, she came back 8 months later, having had some return of exertional symptoms. Importantly, her profiles have improved. This is her. She comes back to the cath lab. That's a pretty cool result. The problem is she's progressed her disease distally. Now, I had elected not to treat any of that distal disease. And actually, I think now outside the study, I would probably treat all of this at the point of index. But she has progressed disease distant from the diagonal bifurcation.
Sigh of relief for you.
Yes. Yeah, but she counts as a TVF. But that's not a failure of the device. It's a failure of the disease.
Yeah.
And I think that's an important reflection here. So we've actually gone back and we've re-IVUSed, and you see beautifully the healing at the level of the bifurcation. It's not a perfect lumen, but she's got enough area for this not to be of ischemic potential. And actually, this was done by one of my colleagues in Bristol, who then went on and actually proceeded with repeated DCB to the distal vessel. So there's preparation of both the main vessel and that smaller diagonal branch, and actually goes back and uses a 3-0 balloon after that IVUS to the mid vessel. Doesn't treat this distal lesion. Actually, I probably would have gone on and treated this as well at the same time. But that was the final result achieved with sequential DCB to the more distal lesion. That's an event in the study, but actually I think it's a success potentially for the patient. You could criticize, but that for me is the reflection on this specific case. But I think it does demonstrate that with complex disease, the uncaging, the fact we didn't deploy stents, I think made actually both the index treatment and subsequent treatment a lot simpler. And so it does then offer up this idea that maybe with DEB upfront approach that we might, kind of embark on a new era. I don't think it's an either or for every case, but it offers up the potential to tailor our treatment to the lesions and to the patients that we're treating every day. Thank you.
Thank you very much, Tom. We have time for some small discussions, maybe.
So if it was stented, there will be stent thrombosis. In that case, it will be more. Now we have diagonal, big diagonal, and positively remodeled the proximally. So that procedure helped the patients more to make the next event less dangerous. Easy. Not only that, if reached, those 5% and 4%, 0.9 difference, those 4% stent failure are more difficult to deal with if it is the DeNovo or Bizzle, no cage available.
Yeah.
Okay. Go ahead.
I think we are tying the most fear actually of using the DCB, the DEB or the DCB is the dissection.
Yeah.
And what I found, and we need a study on this, that if there is an impairment of the flow or there is anything interrupting the blood with the pathology itself, the atherothrombosis, if we have the thrombosis part of the atherosclerosis, what I mean is that if there is impairment of the flow or if the dissection contained hematoma, I think in this case, we need to stent, and this is what we are afraid of, to have an acute occlusion. Otherwise, what I have found, the dissection, whatever it is, even if it is big, if it is intraluminal, it does not show the acute occlusion. So we need the blood part in the lesion. So that's why we may say the controlled dissection. Even if you have a dissection, you modify that dissection to make it more dissections, same as Kettering technique, but I hate actually Kettering technique because you may increase the dissection. So instead of moving the balloon while it is cutting, is to repeat inflating it in different dimensions. So you make it as a mesh, so you allow the drug to go to the subintimal space and to prevent the restenosis.
Yeah.
Definitely all of this needs studies to prove it or disprove it.
Yeah. Okay. Any question?
We're running short on
Yeah.
time, so maybe last question.
I have a question that now we are dealing with a lot of post-DCB patients and they are coming with restenosis, and then after the procedure goes away, how do we medically manage them? Because we are converting a lot of patients mostly into a chronic coronary syndrome. So inflammation is going to be a part of treatment in this?
So probably from my limited experience, the most common cause of failure of treatment, and we need to be cautious about that, is improper lesion modification. You use any balloon, you use an NC balloon, and you see how it's okay, it's 40%, and you throw in the balloon as you're throwing in a stent, and then he comes back. So before going for DCB, please invest more time in modifying the lesion properly. And dissection, of course, antiplatelets are extremely important. Anticoagulating the patient during the index procedure is extremely important. Medical therapy is extremely important as well. You need to bring their LDL below 55, control their blood sugar with good medications, and take care of the regular risk factor control.
Yeah.
Last question, please. Yes.
Now, big bulk of our daily practice, you are dealing with the octogenarians. And those patients, you have two fears. They are non-compliant for the medication. They might have an event, fractured femur, and he will stop, and GI bleeding. And at the same time, they have more complex lesion, needs a lot of work. Do you trust this strategy in those group of patients? Especially your group was in the 60s.
As I showed you, it's only a signal from the secondary analysis, but actually HBR, high bleeding risk patients, seem to benefit the most from this strategy for the purpose of the fact that you could potentially withdraw or interrupt the antiplatelets without the fear of the stent thrombosis. So I think that's stuff that we have to explore that further. It's only hypothesis generating from the information we have, but 20% of the cohort, the 3,500 almost patients recruited, were HBR, and they seem to benefit the most, those in the severely calcified lesions. So I think there's more to learn.
In your practice, you will continue to adapt for how long?
We continued out. We treated both arms of the study in the same way.
No, I mean your practice.
So we treat up to 6 months to 12 months, but generally 12 months post ACS.
Don't forget it's an ACS
therapy.
You created an ACS.
The same. It depends more on the initial disease pathology. If it's an ACS, there is the plaque that you treated, but there are also other lurking plaques in the rest of the vessels. So dual antiplatelet is important. I keep them for 12 months unless the patient bleeds, or unless the patient needs to go for a non-cardiac surgery. In that situation, I'm much more comfortable with the DCB than with the DES.
Yeah, agree. So this is what I'm doing, follow the guidelines so far, but I have low threshold to make it single, Plavix, clopidogrel alone, or ticagrelor alone. Okay, so take-home messages. So now we do have evidence. And that evidence in a large scale DeNovo PCI trial shows solution DEP works in a real world patients. SELUTION SLR DEP is a viable, leaving nothing behind alternative to DS. And this is the price of waiting with the preparation, more preparation, just to leave behind nothing. So I think it's worth it. The DeNovo trial demonstrated broad applicability, even in high-risk complex lesions. That's the example Thomas bring. It's really complex. Proximal, bifurcation, distally diffusely disease. This is what we call complex procedure. Potential for paradigm shift toward DEB-first PCI. Data support a shift in PCI strategy and prioritizing visual preservation, reduce implant burden and flexibility for future intervention. Not only that, also tailor the adapt to make the lower threshold to get rid of one of the dual antiplatelet therapy. Thank you.